Welcome to our webinar titled Diagnosis and Treatment of Bronchiolitis Obliterans Syndrome After Transplant. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our specialists cannot answer any specific questions related to your health care. Today's specialist is Dr. Cheng, who is a pulmonary critical care specialist who treats patients with respiratory problems related to cancer or cancer treatment. At Seattle Care Alliance, she serves as the medical director of the Pulmonary Outpatient Consult Service and provides care through the Lung Cancer Early Detection and Prevention Clinic. Her research is focused on improving outcomes for patients who experience lung complications following a stem cell transplant. A primary area of interest is Bronchiolitis Obliterans Syndrome, and her goal is to improve the prevention and early detection of this disease. Thank you, Dr. Cheng, for joining us today.
Thank you, Lee, for having me. And these are the best kind of talks to give, the patient-oriented ones. And I hope I can answer everybody's questions at the end of the session. Okay, so I'm going to go ahead and share my screen. Okay, so as Lee mentioned, I'm going to talk about the diagnosis and management of BOS after transplant. And this is specifically after allogeneic transplant that this is relevant to. Just by way of introduction, I have no financial disclosures related to this talk. And yes, I am indeed a pulmonologist, and this is a big part of what I do here at Fred Hutchinson Cancer Research Center and the Seattle Cancer Care Alliance. So today we're going to talk about what exactly is Bronchiolitis Obliterans Syndrome after stem cell transplant. How do we diagnose it, and what are the treatment strategies? First of all, let me give you a context of lung problems that occur after transplant. So lung problems are very common in general, and they're really second only to infectious problems in long-term survivors. And in patients who have cancer patients who have undergone stem cell transplant versus cancer patients who have not undergone stem cell transplant, these problems are even more prominent. So what are the lung conditions that affect survivors of stem cell transplant? Well, of course, there's bronchiolitis obliterans, and this is the subject of our talk today. A lot of what happens is actually related to chronic graft versus host disease, and BOS is actually a manifestation, now considered a manifestation of chronic graft versus host disease. There are a number of other entities that are probably very possibly due to chronic GVHD, including an entity called cryptogenic organizing pneumonia, some other interstitial lung diseases that occur in other clinical contexts, non-transplant contexts, and pleural disease. These have not been formally associated with chronic GVHD, but we as a medical community think that they often are related to GVHD. And then there are a lot of problems that arise kind of because of graft versus host disease that occurs outside of the lung or the chest wall, and specifically neuromuscular weakness that can occur as a result of chronic steroid administration, or people who have sclerotic changes, sclerotic graft versus host disease of the skin can get chest wall restriction. And that, in addition to pulmonary emboli or blood clots in the lung, comprise the spectrum of lung disease that's not considered infectious after stem cell transplant. And about, just to give you a context, about 20% of patients who survive past the first 6 months of their transplant process will develop some non-infectious lung problem. And I just want to make a note of this entity that I mentioned, cryptogenic organizing pneumonia, versus BOS, Bronchiolitis Obliterans Syndrome. Sometimes they're confused because the terminology seems somewhat similar, but I just want to make a mention, because this COP entity is probably the second most common process that we see. COP is actually a process that affects the lung air spaces, or the alveoli, where air exchange occurs, as opposed to BOS, which by definition affects these small airways, or the bronchioles. Can COP be related to GVHD? We think probably yes, but it's not part of the formal definition, which I'll get to in a bit. So, and I just want to mention, cryptogenic organizing pneumonia, often commonly misdiagnosed as an infectious pneumonia, but it is treated with prednisone, and the prognosis is generally good, but might progress to fibrosis in some cases. So these are just CAT scans of the lung, just to show that these, the white areas, these infiltrates, if you will, or consolidations, are pretty typical of organizing pneumonia. Okay, back to BOS. What are the basic facts? What do we know about BOS that occurs after stem cell transplant? It's not particularly common. It occurs about 14% in patients with chronic GVHD, and if you take all allogeneic transplant recipients, it occurs in maybe 3 to 10% of these recipients, depending on what study or which center you're looking at. It's usually diagnosed 6 months after the first 6 months of transplant, and generally around a year, 18 months post-transplant, though we have seen it happen as early as 3 months and as late out as 8 or 9 or 10 years. But usually, if it's recognized, it's usually within the first year, year 1 and year 2 after transplant. So the nitty-gritty of how it's diagnosed. The diagnosis is basically predicated primarily on pulmonary function testing. CT scans are helpful, but sometimes not always diagnostic. And then sometimes a bronchoscopy or a biopsy may be required, either to rule out an infection that might be complicating the picture, or to actually prove the underlying pathologic lesion for the purposes of a of a clinical trial. So how does BOS present? And I imagine that there are some of you out there that have experienced this. So patients, survive their, get past day 100 and they're doing okay. They may get diagnosed with chronic graft-versus-host disease somewhere else, like either of the mouth or the skin. They get put on some treatment for it. Things are getting better. Their steroids are tapered. They may develop a new cough or some shortness of breath. It's often misdiagnosed sometimes as a bronchitis, and patients may get a course of outpatient antibiotics that doesn't resolve, and then patients come in for evaluation, become short of breath, and are found to have very, very reduced lung function. So the FEV1 on this y-axis, this is denoting your lung function. And so this is normal lung function. And then you can see that sometimes it can happen in a matter of several weeks to a few months. And then after diagnosis and recognition, most people are generally stabilized, but may suffer other bouts of infectious pneumonia, okay? And then if there continues to be shortness of breath or decline in lung function, people are treated with second-line treatments. So we often, I know a lot of the most important question, pressing question for many is, well, what's going to happen to me after this diagnosis of BOS? And so what is the prognosis? Historically, the prognosis in the early days of transplant 30 years ago, the prognosis was not very good. But over time, because of improvements in the supportive care and improved regimens after transplant, prognosis has improved. Basically, in terms of what is going to happen to your lung function trajectory, this little graph from a study that I did just to show you that if day 0 is the day of BOS diagnosis, you can see that most of the decline occurs probably in the several months preceding this diagnosis when people are maybe not particularly symptomatic. But after diagnosis, for the most part, the lung function does plateau, and it's not clear. In some cases, it may be because of the treatment. In some cases, it's simply because that's the lung function was just simply going to plateau. For a small but significant portion of patients, lung function does continue to decline. I think it's probably related. We think it's related to respiratory infections. So those individuals who continue to have recurrent lung infections, their lung function gets worse. Overall survival, it does, having a diagnosis of BOS does increase your risk of not surviving, maybe 1.6 times what it would otherwise, which is true of sort of any GVHD or severe GVHD manifestation. However, I have managed patients who have survived many, many years, even with very poor lung function. And people can get by and manage. And there are individuals who, if we are able to detect the lung dysfunction early, sometimes do in fact see some recovery of their lung function. So how does BOS actually happen? Because this is really important, and we are trying to figure that out in order to improve our ability to diagnose and treat this process. We hypothesize that it's triggered by some insult to the small airways, whether that's a viral infection, some inhaled toxin, or reflux disease, aspiration of gastric contents, which has also been shown in patients who have lung transplantation. And this lung injury at the level of the small airways results in some inflammation. And because you've gotten a transplant, those cells that were from somebody else are very, they get activated and they come to this area of injury in the small airways, which then, if it's not treated right away, leads to chronic inflammation. And then this chronic inflammation leads to a process called fibrosis, where there's fibrotic material that's deposited around and inside the airways, which then leads to what we call airflow obstruction. Okay, so how do we figure out that if somebody actually has airflow obstruction? Well, we send them to a pulmonary function laboratory. And if you've gone through transplant, you've probably experienced being in a pulmonary function laboratory where there's a technician who sits with you. You have to put your mouth on a mouthpiece and blow really, really, really hard. So this is this is my pulmonary nurse practitioner, actually, Maggie Guerrero, who's my partner in crime in the clinic. She's performing a spirometry. And then this is our pulmonary function technician, Janet, who is directing her to do her breathing maneuver inside this so-called body box, which also measures your lung volumes. The pulmonary function test also measures how well your lungs are exchanging oxygen. So what do we find out from this spirometry, this blowing maneuver? We're looking at at how much air you blow out in one entire forced exhaled breath. And specifically, we're looking at the forced expiratory volume in the first second. So how much you blow out in the first second. And this is what we call a spirogram, where you see the flow volume loop. And this gray line is a normal spirogram of somebody blowing out. But in somebody who has airflow obstruction, this FEV1, what's happening in the first second, is really reduced, and you get this really scooped out exhalation. Okay, so this is a classic flow volume loop, this red line for somebody with airflow obstruction. You can see the same type of pattern in somebody who has, say, active asthma or COPD from cigarette smoking. Okay, so what do we see on a chest CT scan? So chest CT may show something called air trapping, which is, so you see these areas that are kind of more dark than these other areas. This is somebody on exhalation. When you exhale, you're trying to empty your lungs of air, but if your small airways are plugged up or obstructed, then the air gets trapped and it shows up as basically darkness. So black is air, and on exhalation, everything should look more grayish, but in these areas, the air is trapped. That suggests that there is small airways obstruction. Somebody with really severe bronchiolitis may also have dilated larger airways. This is called bronchiectasis, and you see this person with a very low FEV1 of 25% predicted also has the lungs look very dark, meaning that there's probably a lot of air trapping, and these large dilated airways that occur because of the obstruction causes the extra pressure dilates the larger airways. What do we see on pathology? So if we do get a biopsy, we do see that the small airways are obliterated by fibrous material. And so this dark, these dark lines here, that's the outline of a small airway that's been filled in with this fibrotic material. Okay, over here is like some normal alveoli. This over here is a blood vessel. So every small airway is accompanied by a blood vessel. And this is here, you could see the comparison that this should be open, whereas it's all filled in now. So you can see that this would lead to airflow obstruction. Hence, patients feel this as breathlessness, cough, and lack of oxygen. There is a formal definition that of bronchiolitis obliterans syndrome after stem cell transplant that is put forth by the NIH. Basically, a bunch of experts in GVHD got together some years ago to come up with a diagnostic criteria to basically help doctors, categorize people and make the diagnosis. And it's based on, and I don't think I need to go through all the details, but it is based on the spirometry, where you have, there is evidence of airflow obstruction and airflow decline. You really shouldn't have a respiratory tract infection, because having a cold or a pneumonia, that can definitely lead to airflow decline and obstruction, but that's sort of a more confounding diagnosis. You can have some supportive findings of air trapping by the CT scan or by the lung volumes that are measured in the pulmonary function lab. It is, if you do have some graft versus host disease outside of the lungs, so most of the time, the vast majority of the time, patients with BOS already have a diagnosis of some graft versus host disease, though on occasion, rarely, bronchiolitis obliterans syndrome is the first diagnostic manifestation of GVHD. And if there is no other GVHD and you need to prove that this is what's happening in order for you to qualify for a GVHD trial, then a lung biopsy may be required. Most of the time, at least in my practice, I'm not obtaining lung biopsies because it's, there's some risks involved. Most of the time we can recognize bronchiolitis obliterans syndrome from this definition. But there are some limitations to this, and this is the tricky part of clinical medicine, that it's rare enough that I think for a lot of transplant recipients who are not at a, may have been transplanted at a smaller center or at a center where they don't have specific lung expertise, that this definition, it definitely doesn't recognize early disease. You have to, because it specifies that you have to have a decline in FEV1 of, a specific amount or below 75% to meet that criterion. Whereas some patients, they go into transplant already with a great, very, very super normal baseline FEV1. And for them, those patients, if they get to 80%, that's already a big decline. And that might mean that it's early disease, okay? These criteria are not sensitive nor specific, meaning there are other conditions that could also show those criteria. Organizing pneumonia, like I mentioned, may also do that. Some forms of interstitial lung disease, asthma exacerbations, people who are smoking or vaping or using marijuana. And it doesn't account for some of these atypical phenotypes, meaning there are some different patterns that may also show up, different patterns on the spirometry that may also mean bronchiolitis obliterans syndrome, but not meet that definition entirely. And that is also really very true in younger patients because of the physiology of the lungs of a 15-year-old, for example, is actually quite different than somebody who's 70 years old. So it can definitely be challenging. Can we hone in on who actually gets bronchiolitis? Well, so bronchiolitis, it does happen really in patients with allogeneic stem cell transplant, really not so much in autologous transplant, though it has been described very, very rarely. The number one risk factor is chronic GVHD. So if you don't have chronic GVHD, or you got a regimen, for example, post-transplant PSI or cord transplant, where the risk for GVHD is much lower, then you're much less likely to get bronchiolitis obliterans syndrome. Low immunoglobulin after transplant is a risk factor because that probably suggests that you're more prone to having infections. And infections we think can trigger lung injury and small airways disease. And then we do know that if your PFT at your day 80, day 100 time point is abnormal, then you are also at increased risk. How much is we're still working that out. Other possible risk factors, lung problems before transplant. I mean, if somebody has smoked or they already have COPD, we think that is probably a risk factor. Certain kinds of chemotherapy can be very bad for the lungs, and people may not realize that they have some lung injury from their chemotherapies. Radiation is also part of that, and we do know that having high doses of TBI, for example, is a risk factor for early problems after transplant that might land you in the intensive care unit. It's not entirely clear for late problems, but we think that it probably plays a role. And then viral infections, and I sort of highlight this because viral infections are just really common after transplant because of all the changes in your immune status and the immunosuppression and your low IgG levels. This is an area of active research, and obviously it's really quite relevant right now in terms of the pandemic. We do think that there is a linkage between having a viral infection and getting BOS, and that's been shown in lung transplant. So what are we doing to screen or monitor patients for bronchiolitis obliterans syndrome? Because this is really an important point, because oftentimes when patients are already symptomatic, then you do the PFT and then we find out that their lung function has really diminished by, say, 50, 60%, okay? Well, by the time somebody becomes symptomatic, it's like, well, you've already lost an opportunity to potentially intervene, okay? So there are recommendations for some pulmonary function monitoring after transplant, and I just show this on this graph where, you do have a baseline before you go to transplant, one at day 80, day 100, one at 6 months, and yearly thereafter, okay? And then high-risk patients, such as those with chronic graft-versus-host disease that, diagnosed sometimes, around 6 months or a year, really, we do recommend getting pulmonary function tests every 3 months, at least at the minimum for patients who are on steroids or some immunosuppression for their chronic GVHD. But it's clear to me from talking to other practitioners at other centers around this country that the PFT practices are very, they're different based on every center has their own way or schedule for PFT monitoring, and it's not uniform throughout the country. I am conducting a little study here at the Fred Hutch. Actually, it also involves 2 other centers in which we're targeting patients with chronic GVHD, namely those who are at high risk, for early detection with home spirometry. Because doing a pulmonary function test that frequently can be kind of inconvenient for a lot of people, and particularly now in the era of COVID, if you have to go and get pre-test every time. I mean, that's really not super convenient. So there are technologies out there now that I think can overcome the problem of frequent lung function monitoring for patients who are high risk. So this is something that I think could be important in the future for maybe reducing the mortality or, and morbidity of this disease, particularly since we think that early detection is actionable. So say if we do find early changes, is it something that we can treat and reverse and potentially prevent worse lung function decline? I think it is quite possible. And that is based on a study done by colleagues in France, where they gave an inhaled corticosteroid and bronchodilator to patients who had newly diagnosed BOS after transplant, and found that those patients who got the medication had some improvement in their lung function at 1 month. And most of these patients had milder disease than the patients seen in the United States who were participating in similar studies. So I do think that early detection is going to be helpful. Now, what exactly is the first-line management of BOS? My recommended first-line management is a so-called FAM plus LABA regimen. And what is FAM? It's fluticasone, which is an inhaled corticosteroid, and you could also use budesonide, which is inhaled corticosteroid, with or without azithromycin, and I'll explain this in a second, with montelukast, Singulair, which is a leukotriene inhibitor. Okay, LABA, L-A-B-A, is a long-acting beta agonist, and basically this is a medication to dilate your airway, okay? Now, the use of systemic corticosteroids, that is prednisone, may or may not be prescribed, I think depending on how symptomatic somebody is, how severe the lung function decline, and this practice I know varies from center to center as well. It certainly can be used. It's not absolutely required for initial treatment, particularly if the disease is early and mild. But I will say make prolonged prednisone, like for months and months and months, specifically for bronchiolitis, is really not beneficial and is more likely to do harm from all of its side effects than to improve somebody's lung function. And our goal for management is really to prevent further decline of the lung dysfunction. So I just wanted to show you these inhaled corticosteroid and bronchodilator combinations because it can be very, very confusing, all these different medications. These are all medications that are given for asthma and COPD, and you may be on or have heard of Symbicort, Advair, Dulera, Breo. As far as I'm concerned, they're more or less equivalent, and the reason to prescribe one over the other often has to do with what patient's insurance will cover. And sometimes the delivery method, some people prefer like an HFA formulation versus, you know, the dry powdered inhaled formulation. And then there's also another class of drugs called long-acting muscarinic formulations that we give routinely in chronic obstructive pulmonary disease, so patients with smoking-related lung disease, that can be effective. These are not steroids, these are bronchodilators, and they're generally really quite benign. And for some people who have really, really bad shortness of breath, they can certainly be helpful to relieve that symptom. And the most common one that I use is called Spiriva. You might have heard of Incruz or some of these other ones. There's like a new one that comes onto the market every couple of years. Okay, so then here's a question that I get a lot from patients as well as practitioners. Should I be taking azithromycin for BOS? So we all know azithromycin is a very common antibiotic that's given a lot for bronchitis. We added into this so-called cocktail a FAM. In 2017, a randomized controlled trial came out in which azithromycin was given early after transplant in order to prevent lung problems after transplant. So these patients were randomized to either getting, these were stem cell transplant patients, randomized to getting azithromycin or not. And the results of the study suggested that azithromycin was not good at preventing lung problems later on, okay, as it does in lung transplant, but also that the patients who got azithromycin did worse, they died more frequently, and it turned out to be, it was because of hematologic relapse. So there was an FDA and the European Medicine Agency sent out a warning saying, okay, do not give azithromycin early after stem cell transplant because of this potential connection with hematologic relapse. Okay, so what does that mean for using it in the context of BOS? So most patients with BOS have already engrafted. You're farther along after your transplant. Your risk of relapse goes down every year. So, you know, we did do a study to look at this, whether there was increased relapse in patients who actually got azithromycin for BOS, and we could not find that. And I think it's because the rates of relapse in patients with BOS are just simply so low that it's hard to detect a signal. That said, and that is for the reasons that I just stated, that patients with BOS are usually diagnosed, you know, a year or further along in their post-transplant survival course. You know, the pros of it, azithromycin is really very useful drug for a lot of lung diseases such as cystic fibrosis and COPD, and specifically reducing infectious exacerbations. We think that could be the case here in BOS too, though we haven't been able to definitively show that. It's generally well tolerated. That said, why would you opt not to give azithromycin? The risk of relapse, as I mentioned, so for somebody who had, say, high-risk disease, and this may be less relevant for patients with aplastic anemia, okay? Azithromycin, given long-term chronically, appears to have an increased risk of subsequent malignancies. So for anyone who survived a transplant, knows that, you know, there are other subsequent malignancies that come up because of immunosuppression. So this is, you know, similar to what you might see if you're on mycophenolate mofetil or methotrexate or even prednisone. It is associated with arrhythmias. That's been well known, and we haven't really been able to show that azithromycin improves lung function at all. That said, none of the medications that we have used for BOS really improve lung function long term. So the upshot is the decision to use azithromycin or not, I think, is going to be very individualized. In my practice, if they're far enough from transplant and they don't have any other issues regarding relapse or their risk profile, I do give azithromycin at least for 1 week or at least for 1 month in this process. And if everything's stabilized, then I try to take it off as quickly as possible. Okay, so then what happens if you get treated and your lung function gets worse? Well, number one is to investigate and treat the exacerbating factors. The specific second-line treatments that we go to here at the Fred Hutch include extracorporeal photopheresis. Ruxolitinib is a possibility, as is ibrutinib, although I don't find the latter particularly effective. What are the exacerbating factors? Infections, like I had mentioned, definitely an exacerbating factor. Sinus disease, you want to try to fix that because whatever is up here in your nose ends up down in your lungs, and that can worsen the immune reactivity. Aspiration, very, very common, and as is reflux. So that also known to exacerbate all sorts of other types of lung disease. And then environmental factors, so definitely no smoking, no marijuana, no vaping. You know, if there are issues if the air quality is poor in the household, that should be mitigated. There are a number of agents that are currently being tested for BOS after transplant. And so transplant, I'm talking about transplant, stem cell transplant, as well as lung transplant, because the same process occurs in patients who have gotten lung transplant, okay? And so these are are some of the agents that are currently in clinical trial, and one can look them up on this site, clinicaltrials.gov. Ruxolitinib, like I had already mentioned. Pirfenidone and nintedanib are two agents that are used by pulmonologists to treat idiopathic pulmonary fibrosis. And we are also trying to test this and treat BOS patients with these agents to treat the fibrotic process that leads to permanent airflow obstruction. And then there are a couple of other agents, this neutrophil elastase inhibitor and inhaled cyclosporin, though this particular agent is only available for lung transplant recipients. And then last but definitely not the least, supportive care is really important in helping people feel better. Supplemental oxygen if necessary. Unless it's very, very severe, you won't need supplemental oxygen. I know a lot of patients who do quite well without this. Airway clearance, again, this is in an effort to reduce infection. For some people, if they have a lot of productive cough, sputum production, this is useful. Pulmonary rehab is really excellent, and I recommend this for anybody with a chronic lung disease, and that's if you can improve your muscle strength and your endurance, you will definitely improve your breathing and how you feel, and the prevention of infections, as I had mentioned. And then very, very last, for people with really severe disease on oxygen, is lung transplantation an option? The answer is yes. However, the lung problem has to be the only problem that you have. So for patients who have morbidities, problems from other GVHD like sclerosis or heart problems or severe GI problems, probably not, lung transplant is not going to be available. The process can be complex. You do have to be, most centers are asking, won't look at somebody who's not at least 5 years out from their malignancy. I think this is less, maybe less relevant for people who get transplanted for non-malignant processes such as AA. But lung transplant centers are very, very strict. Lungs are a very, are a rare resource. But if you're on minimal immunosuppression and on oxygen and you're at least 5 years out, you could be evaluated. The eligibility criteria varies from center to center. And do patients with lung transplant get BOS again? Well, again, unlike stem cell transplant, patients with solid organ transplant need to be on some degree of immunosuppression for their entire lives. You need to undergo rehab. It's quite involved. It is life-changing and life-saving for many patients with chronic lung disease. But there is a risk of developing BOS in lung transplant. About 50% of patients actually develop BOS within 5 years of their lung transplant. So it's not a walk in the, it's definitely not a walk in the park, but for some individuals who are younger and otherwise healthy other than their lungs, it is an option. So the last thing I want to leave you with is that if you have this diagnosis, I think a lot of it is just simply coming around to how to live with BOS, okay? And a lot of that is, the interaction between using your medications, the inhaled steroids, avoiding infection, avoiding exacerbating factors, doing your pulmonary rehabilitation, and also being in partnership with your transplant oncologist and a pulmonologist, and kind of understanding where you are at and how to manage the limitations from lung dysfunction. I do have patients who have lived quite a long time with this process. So with that, I will close, and I'm happy to take any questions.
Thank you so much. We have a few questions. We'll start with, what types of chemo give a greater risk for developing BOS?
Okay, so that's hard to say, because we do know that there are certain chemotherapy that cause acute lung injury. So early on, so really tough regimens, maybe like busulfan, the taxanes. We have never really been able to definitively show that any one of them is a definitive risk factor for for bronchiolitis obliterans, because BOS happens much later. But we do suspect that chemotherapy, so people who are heavily pretreated, who had multiple rounds of therapy before their transplant, are probably at increased risk.
Thank you. And this question, I'll read. It says, wow, you literally answered my 2 questions during your talk. Out of the drugs are in trials, what in your opinion shows the most promise, and what are you recommending for patients?
Okay, so I'll go back to that screen. So I think that the antifibrotics, pirfenidone and nintedanib, if given at the right time, definitely have promise. And I know that pirfenidone is being tested at Stanford. My colleague, he just completed enrollment. And I think, we are actually going to be talking to the companies about expanding this. I mean, these are agents, the only 2 agents that are FDA approved for pulmonary fibrosis, so idiopathic pulmonary fibrosis and other types of pulmonary fibrosis. It's not a panacea. We think that they slow down the process. It doesn't reverse the process, but at least even slowing down process in somebody who continues to decline, I think is I think a worthy goal.
Thank you.
So I hope that answered that question. Yeah.
You may have answered this previously, but we have a question that says, what is the average life expectancy of a patient with BOS?
Okay. So, I think this really depends on how severe and what the trajectory of the BOS is in the first year after diagnosis. So really early BOS that occurs before 1 year post-transplant, the early, very, very severe and rapid decline, those patients have a harder time. Right now, the 5-year survival for all individuals with BOS in the most, contemporary era of transplantation, the last 20 years, is about 40%. 2-year survival is about 70%. So, but there is a large range within that.
Thank you. To have a history of a pulmonary function, do you practice a baseline respiratory test on every patient that is going to have a transplant?
Absolutely. Absolutely. Every single transplant, every single patient who is going to go forth with transplant should absolutely have a pulmonary function test, no matter where you are transplanted. I think because I'm here at the Fred Hutch, which pioneered a lot of the transplant, I mean, I assume that this occurs at every transplant center in the United States and in the world. And it still surprises me when I find out that that's not happening routinely everywhere. Sometimes it doesn't happen because patients are unable to do it. And that's and also in the context of the pandemic, when a lot of the pulmonary function testing labs had to close down for a period of time because of COVID, but people still had to move forth with their transplant. Some people didn't get them because of that, but if it's feasible and safe to do, you should absolutely have baseline pulmonary function tests.
Thank you. This question reads, GVHD occurs on autologous transplant patients or just to those that have had an allogeneic transplant?
It's just an allogeneic, yes, because you're getting cells from somebody else, whereas autologous, you're getting your own cells. So you don't actually, the cells recognize yourself, so you don't get graft versus host disease if you have an autologous transplant.
Thank you. Is it possible to have BOS without symptoms?
Yes, it is. And there are definitely individuals with milder disease who do not have symptoms. Mm-hmm. And so sometimes it's not recognized because patients, their doctors are not ordering the pulmonary function test if they're not complaining of symptoms. And then sometimes they're done for whatever reason, and we do see a decline. And if it persists, then yes, they meet the definition of BOS.
Thank you. This individual would like to know how much steroids are typically given at diagnosis of BOS, and then is there ever a slow taper?
Okay, so the dosing of steroids is generally around 0.75 mg per kg to 1 mg per kg, and for an average person, that ends up being something like 60 milligrams. So it might be somewhere between 60 and 80, and sometimes it could be, if the patient's not terribly symptomatic, like 40 is permissible, is fine. I mean, that's a moderate, decent dose. I do not recommend a very prolonged taper. I recommend that if they're really, most of the time, lung function is stable, and then it really is quite safe to taper it off over 4 to 6 weeks. I don't recommend a very prolonged taper unless there are other GVHD concerns that need to be treated with prednisone that require a longer taper. But for the lungs, I've never seen a prolonged taper be particularly helpful. It puts you at risk for pulmonary infections. People get weak. People have also, the side effects from prednisone are really obviously not great.
Thank you. Can cardio exercise and pulmonary rehab help improve lung function and PFT results?
Absolutely. Yes. And this is why I recommend it, because pulmonary function tests, it's an effort dependent process. Okay, part of it is, so if you are not able to blow because you're weak, that can affect your result. Okay. It doesn't, so the rehab and the exercise is not going to fix the small airways obstruction, but it can help the rest of your lungs, the good parts of your lungs. That can compensate for the parts that are obstructed. So yes, absolutely. I think pulmonary rehabilitation is excellent. Unfortunately, I think it depends on where you are, that the programs, there aren't that many, it depends on where you are, how accessible those programs are. There are definitely things one can do short of attending a formal pulmonary rehab program. Simply just walking or, doing some of these kinds of exercises at home, um, it's all good. The whole concept is basically you're trying to improve your endurance and gain some strategies to relieve your shortness of breath.
Is it recommended for BOS patients to get the pneumonia vaccine?
Yes, yes. So
And
any patients, I mean, you follow the same recommendations for any long-term survivors.
does the use of inhaled corticosteroids for BOS have better results using administered via a nebulizer versus a flexhaler?
Okay, so this depends on, a lot of it's subjective. I think that if inhalers can be challenging for people because you have to hold it, you have to hold your breath, and then, you have to have good technique, right? And that can be hard if it's hard to hold your breath. Okay, so usually I recommend using a spacer chamber where you can do relaxed breathing. That said, for some people, just doing a nebulizer is sort of relaxing. It doesn't take, it's a little bit more time, but the overall effect might be better. You might actually get more medication in if you're sitting there and sort of, it's sort of being nebulized, and um, more of it may potentially get down there. It's a little bit subjective, but if an inhaler is not working for somebody, yes, a nebulizer could certainly be tried.
This question comes from a BOS patient who is currently using oxygen. They're experiencing nosebleeds. They like to know, is this common? And are there any tips for having less frequent nosebleeds?
I recommend that the air be humidified. So the nosebleeds are probably because the oxygen, the flow, it dries out the membranes, and that's probably the cause of it. So if there's any way to get it humidified, would be better. And then anything that you can do to, I don't know, maybe a little bit of Vaseline to try to prevent the the bleeding in the nose.
And this question is, if a patient with BOS is requiring supplemental oxygen, does this mean that their prognosis is poor?
Um, that definitely denotes more severe BOS. The prognosis is not as good as somebody who has minimal lung dysfunction. And if it's gotten to the point where one requires supplemental oxygen, and it's, the impact on, and the individual doesn't have additional organ problems, then one could consider pursuing lung transplant.
We do have two questions that look like they're coming from a physician for Dr. If they could send those questions to me to my email address, which is Clark, CLARK, at aamds.org, I can then forward them on to our specialists, because they would probably be better done physician to physician instead of on the webinar. But thank you so much for taking the time today to spend with us. It was a wonderful talk, and for sharing your time and your expertise with us. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send them to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes our program. Thank you so much for joining us today.